Hey everybody, welcome back to part 2 of our ACL reconstruction rehabilitation presentation. As I said in the first half, there's a lot that we could talk about here. There's so much research on this, and we're really trying to pare it down so that you guys can apply it well in your clinics. We reviewed sort of the anatomy of ACL, its attachment sites, as well as looking at MCL and PCL and LCL. So just kind of putting all those ligaments around the knee in your head so that you kind of know where everything is, and talked about what the ACL specifically is used for with the knee and how it resists translation as well as rotational movements for the most part. We talked a little bit about how the pathophysiology occurs and that we can have these non-contact versus contact injuries. And so recognizing that a lot of the time we're not being hit by somebody, we're just planting our foot and then twisting or pivoting or hyperextending the knee, and that's what causes a tear in the ACL. So there are more incidents of ACL tears in adolescent females due to some different reasons, but these tend to be the ones that we see the most postoperatively. And what they use for diagnosis includes, obviously, gold standard is MRI, but in your clinics, you can perform the Lachman's test, which provides pretty good sensitivity and specificity to find things like a torn ACL. So again, we can talk about these tests a little bit more in lab. We talked about the grades of the injury and the fact that a full tear is what's called a grade 3 injury. These are always going to, well, not always, but they're oftentimes going to be the ones that are going to be chosen for surgery. We also went over the guidelines. So there's actually 2 clinical practice guidelines from the Journal of Orthopedic and Sports Physical Therapy that relate to the ACL. And this is the first one, and the revision was done in 2017. And we talked about the recommendations yesterday. Today we're going to talk a little bit more on a topic that follows another guideline that looks at injury prevention. And so this idea of trying to find the right types of exercises for not necessarily our patients, but for anybody who's doing sports to help decrease the likelihood of getting an injury. So if you remember, those who do not end up having surgery for whatever reason are called copers, and our treatment looks very similar to what we might be doing post-operatively. And so we kind of brought up these different Delaware-Oslo cohort studies. We're going to talk about the Delaware-Oslo group again today when we're talking about return to sport. And basically what they found is that there's a good number of people who went as long as 2 years without surgery who were doing okay and returning to function. We reviewed the surgery technique, which I'm not going to go over again. And what we want to keep in mind is that it's important to know what kind of surgery they had. So if they had an autograft, where the autograft was from. So those videos looked at patellar tendon and hamstring tendon. Those are definitely the most common places for them to take tissue to then allow for them to become integrate into what becomes your ACL. And it was really important. We talked about this slide as the most important slide that you guys can have in your head from this presentation, I would say. And this is patient education and helping patients understand the time frame for healing. And this time frame we would want to consider with synthetic ACL, so those man-made ACLs as well. Since we don't have enough research to really know timelines for the synthetic ACL, we're going to pretty much follow the same timeline. So recognizing that between 10 and 20 weeks, that's when all the blood flow is happening, starting to get in there. And it's really when there's the most weakness in the knee and in that ACL, basically. So we want to be careful that people don't try to return to things too quickly. And that's what we're going to spend a lot of time talking about today. Okay, so those are, again, the healing time frames. And then the last thing we covered in the last presentation was the knee soreness rules. And if you remember, basically, this is a nice, I think, set of criterion to consider for any of your patients with any of the exercises, especially if you're more of a trainer and you're focused more on exercise. These are, I think, very nice ways to consider communicating with your patients, talking about their soreness. In this case, this would be soreness in the knee joint, not muscle soreness. So there's a big difference. And if they're reporting knee joint soreness during warm-up as well as throughout the treatment, then we need to kind of scale back. And that's what we talked about the last time. Okay, so let's get into our treatment for these patients after ACL reconstruction. We're pretty much saying that this is an autograft or a synthetic. Allograft is going to go a little bit slower than this, but the time frame should work for most of your patients since I know that allografts are very, very uncommon in China. So the first 2 weeks is the protected motion phase, and it's during this phase that our goals are focused on pain control. Our goals are also focused on range of motion. They should be able to achieve full extension and 90 degrees of flexion by the end of 2 weeks. The extension, you will have surgeons, I did mostly in the US, who were okay and actually didn't want us to push extension during the first 2 weeks. And so you may have surgeons who say that, and that just depends on their surgical technique. But they would say, okay, we're kind of okay. As long as you can get the quad contraction, quad activation, we don't want you to push the extension until about week 3. And so we would definitely kind of follow the surgeon's recommendations. But I have not seen that in China. Either the surgeons just aren't sure, or they don't really know, or they're happy with extension. So that's fine too. So our treatment is going to be pain control as well as performing some sort of exercise every hour. And it's really important that they are performing something, some sort of movement to promote that healing of the graft. And we can also perform some soft tissue work around the area, again, for swelling, things like that. And then we're going to have them work on their extension by considering passive knee extension using something underneath their heel, like a pillow. So they're just hanging out there with the knee in full extension. Basic range of motion, so heel slides, prone, hamstring curls, those kinds of things to help make sure we're allowing for flexion to happen. And then an MES. So remember, we spent a lot of time talking about the research regarding an MES for a total knee replacement. This is another situation where there's great research out there to show that NMES can be really helpful immediately following an ACL reconstruction. And so we're talking about using it to work on extension. So we're putting it on the quad, and it's a really nice adjunct since a lot of these people do not have good quad contraction following their surgery because they probably didn't have it very good before their surgery. We can also start doing some bicycling, usually like the half circle type of thing on a bike, and we can do very small squats. So the squats are going to be from 0 to about 70 degrees of flexion. We're doing mobilization of the patella, and we're going to start doing proprioceptive training. So this is within the first 2 weeks. They should starting to do some single leg stance and things like that. And again, weight bearing as tolerated. So they really should be walking. To progress out of the first phase, they should have full knee extension and good quad activation. Again, these are the biggest, most important things initially after ACL surgery. Phase 2 goes from week 2 to 6. So these 4 weeks, and during this period, again, we want full knee extension and pretty close to full knee flexion range of motion. Again, it's something that can come after 6 weeks and it's fine, so you don't have to push flexion. We've seen several patients, unfortunately, who were seen by somebody who decided they really needed knee flexion, and so they pushed them really hard, And then what happens is those patients end up with a stretched out quad tendon and patellar tendon and quad muscle that makes it really, really hard for a good good quad contraction. So you have to be careful. This is not something, they will get their flexion eventually. I feel like in China, people are way too focused on knee flexion. And with these patients, they'll get there. What's more important is that we're not overstretching the quad. We're working on getting that quad contraction. And we really would like during phase 2, so those first 6 weeks, to normalize their gait and return back to normal ADL. So they should be, at the end of 6 weeks, they should be able to walk and do stairs for the most part and things like that. Second phase, we're going to start doing lunges and squats. Our squats are still not going to really go past about 90 degrees. And you'll see there's a leg press on this list too, and the leg press goes to 90 degrees. Same with lunges. So we're staying above 90 degrees for our loaded knee flexion. But we can start doing cycling and go all the way around on a bicycle. We can do like the step machine. And then a lot of focus during this phase on gait training, especially getting knee extension and weight bearing. So what I've found over the years is that a lot of these patients will be able to tolerate knee extension on the table, and I can get full knee extension with good quad contraction. But then when I get them up standing and have them start walking, and they should get full knee extension during terminal stance with gait, and they're not able to do it. And so you really need to be training these people in knee extension in weight bearing as well as non-weight bearing. And that's going to, of course, then help their gait. So progressing out of phase 3 is range of motion of flexion of 120. Okay, so 120 is pretty good at this point if you can get there. You don't have to push it. And sure, eventually they probably want 130, but that's not something you need to worry about right now. The other big thing is a straight leg raise. They should have no extensor lag. So straight leg raise, they should be able to push that knee down into the table, keep it straight, and lift the leg up in the air and bring it back down without any knee flexion. And I'll tell you, this is a hard thing. So this is something you really work on during this phase. Third phase is week 6 to 12. So we're going to about 3 months here. And if you remember, we talked about that 10 to 20 weeks as being that golden place where a lot of people think they're doing really well and they try to do too much. So we're just getting into that time frame during phase 3. Our goals are full range of motion, increasing our proprioception, and really increasing the ability to do most activities. Again, stairs, things like that. Should be pretty good by the end of 3 months. So we're doing proprioceptive training. Again, remember that we talked about the nerve endings of the ACL. We're not sure what happens to those mechanoreceptors as the ACL starts to incorporate back into being your tissue. So we need to spend a lot of time working on proprioceptive activities, just like when we talked about ankle ligament reconstructions. It's important that we're thinking about trying to get our mechanoreceptors and our proprioceptors to really, really work the best that they can. We can start open kinetic chain activities, so that's going to be things like a long arc quad, but we're going with a range of about 40 to 90 degrees of flexion. And then we, at about 10 weeks, can just start to do jogging. And I'm telling you that I'm not going to say changes in direction at this point. I'm just going to say just straight jogging. So that can start at 10 weeks. So to progress out of phase 3 and go into phase 4, we want them to use an outcome measure. And this outcome measure is called the International Knee Documentation Committee Subjective Knee Form. So IKDC. And this is, this basically, they should score at least a 70. They also should be reporting no history of the knee giving way. So as we're starting to do more kind of return to sport activities, they should be telling you that their knee feels very stable. And then when you do a pivot shift test, it should be negative. They also should have knee extension strength of greater than 40% for males and greater than 30% for females. And this is true at that 300 degree per second level if you're doing this with a KINCOM. And they need to have 60% for male and 50% for female if you're doing it at 180 degree per second. So basically how you can test this if you don't have a KINCOM is they should be able to do a single leg press on a leg press machine 5 times within 50% of the uninvolved side. Okay, so you put them on a leg press, they're doing one leg, they should be able to do 5 reps at 50% or more of the weight of their other leg. Okay, so now we're past phase 3. They've met these goals, and we now are thinking about return to sport. So we put weak question mark because we don't really know. We don't really know when, what kind of time frame this should take. We have a good amount of research, though, that talks about delaying return to sport. And so that's kind of what I want to talk about today and some of the different options that you have for testing for return to sport. So remember, it should start usually about week 12. So again, if these milestones have been met, usually we're starting these kinds of advanced activities at about week 12, but some of your patients, it might be closer to week 14 or 16. So it might be closer to 4 months before we're starting these things. So let's talk about research, because there is a good amount of research out there. This is actually from February of 2020. And what we have found is that certain athletes who return to sport before 9 months after ACL reconstruction, you can read that, have a rate of new injury 7 times that of those who delay return. So if they're going back before 9 months, we're much more likely to have issues. And we're going to talk about the difference between allograft and autograft and how that might affect return to sport as well a little bit later. But let's just look at this research. Again, this research just coming out. Return to sport, if they're doing basically what this particular research looked at is 159 different kinds of athletes: football, basketball, badminton, baseball. They all had reconstruction and they all returned to sport. And so they asked them the timing of their return to sport and their function. And then they assessed these people, they assessed their strength, so quad strength, hip strength, hamstring strength, and then their ability to hop. And so what they found was exactly what the return to sport, or what the label was, is that this idea of if they're going back before 9 months, they're 7 times more likely to have some sort of subsequent injury, usually ACL ligament injury. What was interesting, though, is that there was no association between getting another ACL injury and if the muscle was functioning equally on both sides. So as we go through this list of criteria-based return to sport, we're going to spend a lot of time talking about, well, quadricep strength should be 80 or 90% that of the uninvolved side. Unfortunately, this particular research from February says that there is no association between quadricep strength and their injuries following sport. The only association that they found was this time frame, greater than 9 months. If it's greater than 9 months, they're much more likely to be safe and not have subsequent injuries. So as I say that, let's actually go through these criteria-based return to sport options. So we need something to help us figure out return to sport for these athletes. And so this is Myers research from 2006. We're also going to talk about a more recent one from about last year that kind of helps guide you as well. So Basically, we already talked about this idea of the entrance criteria to start in on return to sport stuff. So this is exactly what we talked about at the end of phase 3. And now we're going to talk about stages of return to sport. There's no timeline for these. You're basically just following the goals and then the exit criteria to move on to the next stage. So the first stage, our goals are basically to be able to do single leg weight bearing strength. So be able to see their strength through different angles of knee flexion. So they should be able to show a single leg squat and demonstrate their strength at different levels of that squat. You also want symmetry between the involved and uninvolved side during running. So we'll take video of running, and we want to be able to see that everything from the ankle foot up to the hip are symmetrical during running. We also want really good balance. So how can we measure all of these? In stage 1, we're measuring that single leg squat. We want to be able to do a single leg squat and hold with at least 60 degrees of knee flexion for more than 5 seconds. So that's how we can measure the squat that we talked about. We also want to, when we're listening to them run on a treadmill, we want them to audibly sound the same on both sides. And, you know, as we do running assessments, we get really technical and put little angles and stuff like that at the ankle and the knee and sometimes even the hip and pelvis. And we're not saying that you need to be exactly the same on both sides for these things, but there shouldn't be any big differences between the left and the right side. And again, when they're running, it should sound the same on both sides. There also should be a single leg stance score on what's called a stabilimeter. And we don't have that. And so in the clinic, basically what we do is we should be able to demonstrate 30 seconds of single leg stance with minimal sway. So they should be pretty stable for 30 seconds of single leg stance. So that's stage 1. We move on to stage 2, and our goals are basically being able to demonstrate very good strength, not just balance, not just control, but actual lower extremity strength. Continuing to show symmetry, and that would be in just weight bearing. So being able to stand on both feet and consistently have equal weight bearing on the involved and uninvolved side. And then as we start to add jumping and hopping, we want them to be able to control their lower extremity during a single leg hop. So how do we measure that? How do we get to these criteria? This slide is going to talk about measurements and things, and then we'll talk about how you can actually do it in your clinic. So it's hard for us to be able to measure peak torque of a knee. And so there are some other ways that we can kind of play with that. But these are kind of the exit criteria that are in the research using fourth plates and things like that. So we don't have that option. So let's talk about how you can test these things in the clinic. So to exit out of stage 2, they should be able to do a single leg press as well as single leg hamstring curl with a 5 rep max within 15% of the uninvolved side. So hopefully you have access to resisted machines, a leg press and a hamstring curl, and they should be able to do that with at least 5 times and within 15% of the other side. Also be able to do a power side plank with hip abduction, and you have them do it as many times as they can, and this should also be within 15% of the uninvolved side. Equal weight distribution with a dumbbell limb squat at 90 degrees. So again, if you have these awesome little force plates that you can have them stand on, they should be equal. And the other thing I sometimes will use is have them stand on a Bosu ball and do a squat, because with a Bosu ball, they have to equally weight bear, or you're going to be able to see that they're not straight, right? So that's another way you can measure it if you don't have like scales or something to put their feet on. And then the last thing is Y balance test. So this is good for that proprioception. So the anterior reach should be within 4 centimeters of the uninvolved side. So Y balance is, we can talk about that in lab a little bit more, but this is specifically the anterior reach. And so that we need them to be able to reach forward similarly on both sides. Stage 3 goals, it's a lot of single limb power and endurance. We're going to start doing a lot more plyometric activities, and they should be able to demonstrate equal tolerance on both legs. So for exit criteria out of stage 3, these are all within 15% of their uninvolved side. We're going to do single leg hop for distance, single leg crossover triple hop, single leg time hop over 60 meters, and then a vertical power hop, and then a tuck jump. All of these should look within 15% of the uninvolved side. So our last stage for return to sports, our goals is that basically ground reaction force to be the same. Again, these are hard for us to measure a lot of the time in clinic, so we have some ideas of how you can do it. But they should be demonstrating good biomechanics with all of these power and endurance activities that we're giving them. So how do we do that? We can use what's called the drop vertical jump, and they should be able to land symmetrically within 50% bilaterally during that drop jump. There also is what's called a modified agility t-test, and the test time should be within 10% of the uninvolved side. We also can do what's called a single limb peak power test for 10 seconds. And we should be able to get that within 15%. And so, again, what you can do is just do 10 vertical single limb hops for time and see how long that takes, and that should be within 15% of the other side. And then the last thing we can do is use the tuck jump. And with the tuck jump, we want to get within 20% of that 80-point score. So all of these things you can find in the literature. I'm not going to go through them in detail. We will hopefully be able to talk about them more in lab so that we can really be able to figure out the best options for testing for return to sport. More recently, there's this wonderful Melbourne ACL rehabilitation guide that actually we've been using in our clinics here for return to sport. We should be able to share this with you guys, but this also kind of gives you that checklist of very similar things to what I just mentioned. Again, this is a little bit newer research though, so it talks about the single limb hop test, the triple hop, and the triple crossover hop test. So I mentioned those previously, and they want you to be within 95% of the other side. And so what's nice about this particular basically booklet is what it is that it gives you the specific instructions on how to do these. Here's a couple of other things. Again, this follows very similarly to the list I already talked about with side hops, single leg squats, and then dynamic balance activities. So again, it basically is saying that you should be able to reach these goals for return to sport. And they give you this nice scoring sheet here that you can use to help as you go through this, put in your numbers and then come up with a total score that will help you decide how close they are for return to sport. So this is such a big deal because we have all of these measurements that we're hoping help, but as I said earlier, it's really mostly about time. And so as we look at patients going back to sport, we want to make sure that they're following these goals and being able to achieve what we've listed here. And we need to focus a little bit more on certain things depending on what sport they're going back to. So this is just a list of, the idea that jumping and cutting and pivoting are really important for things like basketball, soccer, football, handball. But when we're thinking about more of your racket sports, gymnastics, baseball, those kinds of things, then lateral movements are more important. And then when we're thinking about just running or skiing, well, cross-country skiing, not downhill skiing. And weightlifting, then we're really thinking more about straight ahead activities or sagittal plane activities. So there's no jumping or running required. Sorry, there is running, but there's no jumping or pivoting required for those types of activities. So we don't have to focus on those things as much, even though we're using very similar return to sport criteria. So here's some more research. This specifically looks at running, so that sagittal plane movement and criteria for return to sport. Unfortunately, they looked at 201 studies, but only 1 in 5 of them reported clinical strength or performance-based criteria. In terms of returning to run time frame, most of them say 12 weeks, and so that's kind of what we said. We said more than 10 weeks in phase 3 that they can start returning to running. So unfortunately, again, we don't have really great criteria for just somebody returning to running and how to measure that. But this is kind of more of a goal-based criteria. And again, we're really saying you're not returning to full-on running until about 9 months. If you remember, we talked about that at the beginning of this section. So again, this is just showing how we think about returning to sport and kind of the performance, basically starting with just basic returning to running and then starting to then increase and progress. So this is where we say the validity of return to sport testing is not very good. This is a systematic review that just came out a couple, I think last year. And basically they looked at 18 studies and only 23% of the patients passed the return to sport batteries. So basically there's just so little to help us show that there's a direct connection between that return to sport testing that we talked about and actually not having ACL injuries. The return to sport criteria reduce the risk of subsequent graft rupture by 60%, but it also increased the risk of getting an ACL rupture on the other side by 235%. So, which is a little bit crazy, and it's a strange statistic. We spent some time last year talking about this statistic. It's hard to say why it's true. It's hard to say. It's probably because we spend so much time training the involved side that we sort of forget about the uninvolved side. And so we want to make sure that as we're thinking about return to sport, we're thinking about, again, symmetry and trying to make sure that both sides are equal. And so I'm not saying don't do these protocol and then using the criteria that we've mentioned, but unfortunately the research does not have a very good direct correlation between the two. It's all about timing, and this is what the Delaware Oslo cohort study has said. So we talked about them when we talked about other pieces of the rehab, but what they found was after the first 2 years, 30% who returned to level 1 sports, so high-level athletes, sustained a re-injury, compared to only 8% who were in the lower level. So if I'm just a casual runner who runs, a couple times a week, I'm less likely than the marathon runner who wants to be able to win the Boston Marathon. Another big take-home is for every month that return to sport was delayed until 9 months, that rate of injury was reduced by 51%, which is a lot. So again, that 9-month mark is, I think, a very appropriate time frame, and they should be able to obviously meet all the criteria, but we're waiting until 9 months to return to sport. So this says that more symmetrical quad strength prior to return to sport reduced the re-injury rate, but again, that more recent research does not correlate quad strength with re-injury. So I don't know, you can use it if you want to, but recognize that the timing frame is more important than the quad strength. Okay, now that I've sufficiently confused everybody, let's finish up with one more research article that just came out literally this month, May of 2020. This research comes out of JOSPT, and they looked at the different kinds of graphs and how that affects return to sport. So they did use return to sport criteria. It's exactly the same criteria that we used previously, and or that we've already talked about previously. And they compared allograft to patellar tendon autograft to hamstring tendon autograft. So you'll see that there was definitely the most hamstring tendon of the group. And this is something that we have seen in China as well. We probably see a lot more hamstring tendon autografts. And they then did return to sport criteria, which they used strength, unfortunately, but that was greater than 90% quad strength compared to the uninvolved side. They did those hop tests, just like we talked about, and then they used some questionnaires. And what they found was patellar tendon autografts took 1.5 to 2.5 months longer to meet their key rehabilitation criteria, and up to 4 months longer to return to sport. So you say, why is that? And I think it's pretty obvious that if we're taking patellar tendon to replace our ACL, then we're losing patellar tendon. And so we're losing that quad, the ability for the quad to contract. And so if you're using hamstring, we don't worry so much about the hamstring. You'll notice we really didn't talk about the hamstring at all through all of this rehab. And the reason is because we don't care as much about hamstring contraction, and we don't need it as much following ACL repair. But we really do need the quad to contract correctly. And so it takes a lot longer for us to be able to meet the criteria when we're using a patellar tendon autograft versus when we're using a hamstring autograft or an allograft. And then you can just see these figures here talking about return to sport and sort of the weeks that it took to get there. So I'm not going to go into detail here, but what you'll see is that the time made a very big difference, but that quad strength, if you look at the picture on the right, quad strength did not really affect their ability to return to sport. So it's all about the timing, guys. I can't say that enough. Okay, so again, I know this is a lot to cover in one presentation. There's so much more research out there. This is just a very short list of references. We took pictures of the other references so that you can look those up as well if you want to. But again, I would say use the criteria we have, but recognize that criteria is not great. And so really focus on time frame and having them perform a lot of good training up to 9 months, and then start thinking about return to sport.